Hello, everyone, and welcome to Living With. I am so excited to share this time with Dr. Shelby Harris, who is a psychologist and sleep specialist in private practice in New York. She is board certified in behavioral sleep medicine and treats a wide variety of sleep, anxiety, and depression issues using evidence-based, non-medication treatments. Her self-help book, The Woman's Guide to Overcoming Insomnia, was published in 2019 by Norton Books. And Dr. Harris holds a dual academic appointment as clinical associate professor at the Albert Einstein College of Medicine in Neurology and Psychiatry. Before going into private practice, she was the long-standing director of the behavioral sleep medicine program at the Sleep Wake Disorders Center at Montefiore Medical Center in New York City. Dr. Harris has been invited as a columnist for the New York Times and is frequently in the media, including The New Yorker, The Washington Post, CBS Mornings, The Today Show, Good Morning America, and The Drew Barrymore Show. Dr. Shelby Harris can be found on Instagram at sleep.shelby, where she provides evidence-based information about sleep wellness and sleep disorders. But today I'm very excited to introduce you to her and her to you, because she will dispel many myths around sleep and give us lots of great tools and tips for how to manage better sleep health with or without a diagnosis. So welcome, Dr. Shelby Harris. Dr. Shelby Harris, it is such a pleasure to have a few minutes with you today on our Living With series. So welcome to Living With, and thank you for sharing your expertise with our community.
Oh, thank you.
Yeah, it's always good to see you. I'd love to jump in, actually. You are a behavioral sleep psychologist. You're also an author. Mm-hmm. You're very present on social media. I'd love to jump into the role of kind of education, I think, in terms of sleep health. But let's start with, what is it that you do and why are you a sleep specialist?
Oh, it's a loaded question. So I'm a sleep specialist because I, as a child, was a very big sleepwalker. So I would try, one of my clearest memories during childhood, I was maybe 8 or 9 years old, was trying to walk out of my parents' house in the middle of the night, no clue that I was doing it, but setting off the alarm, and my dad coming downstairs with a bat thinking that there was a burglar. And that's how they started to figure out that I was sleepwalking. And it was very scary, but also like kind of fascinating. Like, why would I do these? Like, I had no desire to try and leave house or anything like that. But why was I doing these things in my sleep? And then when I went to before I went to graduate school, I went to Brown University, and they put me on a research study there. And I was a psychology major and also a music major. And the study I was put on was looking at people who were in early rehab for alcohol addiction. And what they were trying to treat at that time was insomnia, because they found that people often relapsed with alcohol because they weren't sleeping. So the idea was, if we treated them, at this time they were using trazodone, which we still use for sleep sometimes, but if we treated their sleep problems in early rehab, did that actually help to reduce their relapse? And lo and behold, yes, it did. And now they actually replicate a lot of these studies in other substance abuse issues, and also with behavioral treatments for insomnia, not necessarily medication. And then this was in like 2000, and that got me started to think, like, why are we not talking about sleep in other areas? Why are we not talking about it in wellness? Why are we only talking about it in like these specific populations? And that's when I went to graduate school, really focused on insomnia work. And when I went to Montefiore, that's where I worked for many years under Michael Thorpe, who does a lot of work, and Mita Goswami, a lot of work in narcolepsy and hypersomnia issues. So that's when I started to see the broader spectrum beyond just insomnia work. And it really is so fulfilling to work with people, because when they start having improved sleep, or they're managing their sleep disorders better, you can see how many different areas of their lives it really does touch. And that's what I do today. I work with patients using behavioral treatments. I'm in private practice now, but still on faculty at Einstein Med School. So I do a lot of teaching, do a lot of public-facing stuff, as we talked about, and I love working with patients, mostly virtually, to help improve their sleep.
Yeah, there's a lot there. I'm so glad that you ended up in this space, because of your contribution has been really significant. So can you tell us what cognitive behavioral therapy is in terms of your sort of work, that context, and in relation to sleep health?
Yeah. So cognitive behavior therapy is this kind of umbrella term that a lot of people, when they think that they're coming to me or they're referred to for CBT, they think it's a long-term therapy. It isn't necessarily. So CBT, cognitive behavior therapy, has been used for anxiety, for depression. It's very research focused. So we have protocols that we will bend to the patient. And they also have CBT for insomnia. That's been around for a number of years now. Very evidence-based treatment for insomnia. And it's very short term. I typically see people for insomnia work 2 to 8, maybe 10 times if they have a very complicated case, where we're changing behaviors, changing thoughts around sleep. And then now we have CBT for hypersomnia as well. So we're using, it's like kind of different treatment techniques in one package. So we might work on beliefs about sleepiness, beliefs about how other people might be judging us. We might work on napping strategies, caffeine strategies, sleep-wake strategies, way to stay up during the day to help with that. And also maybe dealing with family, social stigmas, things like that. So it's really a comprehensive treatment package, and we're finding that that's very effective for many people, and we use it a lot of times along with medication for many people. Right. So those are the two areas that we really will do a lot of CBT for in sleep disorder space.
Yeah, I was just going to say, so this is obviously a non-medical approach, medication approach to managing sleep health, and I think it's sort of an area that can be quite overlooked, maybe neglected. I think the traditional route is to sort of see your doctor, get your diagnosis, get a prescription, and yet there's this huge area. And I know that when you've spoken publicly, mainstream media, you've talked to, the general population, as it were, maybe with an insomnia perspective about sleep health. But what is it that specifically is particularly relevant for people with hypersomnias? And obviously this is an IH-focused and narcolepsy-focused interview. So can you give us some tips for that specific community?
So I think the first thing is to find, like you said, a lot of people just go the medication route, which I think there's a lot of, that's the guidelines for a lot of people, but it's not, it doesn't work fully for everyone, depending upon the presentation of symptoms and severity. They might have side effects, whatever it might be. And then for other people, they might not even be told that CBT is an option. And the reality is that sadly, there just aren't that many people trained in CBT for hypersomnia issues. So there are more and more people getting trained in CBT for insomnia because it's been around for a long time. But the hypersomnias, we just don't have that many people who are really board certified who get the training to do it. So a lot of providers just don't know where to refer to a lot of times, so they don't even recommend it. Like I said, I was at Montefiore and I was fortunate enough to be there, and we were a very multidisciplinary team. So the thing I always recommend to patients is if you're interested in CBT on its own as an adjunctive treatment, go to the Society for Behavioral Sleep Medicine. Look for someone who ideally has a DBSM or a CBSM next to their name. That means that that person has more training beyond just insomnia and that they have followed the board certification to have knowledge in all different areas of sleep medicine, as opposed to someone who just does CBT for insomnia, which is what you're going to find more often than not. So that's the first place. And then also, like I was saying, we will work on, it really depends upon the person, but we will work on caffeine strategies, right? Like how to actually not fear coffee and caffeine, how to use it appropriately, how to think about some people with narcolepsy, or a lot of people have broken sleep at night, but use a lot of caffeine, which can also worsen the broken sleep. So how to really time it properly, how much you want to use, maybe do it with naps. So we will work on napping strategies a lot of times. And then the big thing I see in the narcolepsy community especially is this, for cataplexy, is a fear of wanting to experience emotions. So emotion tolerance, ways to help deal with emotions, not fear them when they're coming up. So that's distress tolerance is another big thing we might do with patients. So there's a lot of different areas to look at. Diet, right? So whether it's a high carb diet that's causing some of the issues, we might try and work on it there. So there's a lot of different, it really does get targeted towards the patient specifically. But as I said, really look for someone who's got that DBSM, because that will guarantee you that they know what they're talking about.
Right. So if a person comes to you, whether they've got, as you said, a diagnosis of narcolepsy or IH or insomnia, you're looking at the patient and their specific needs and sort of prescribing a therapy tailored to them, even though the sort of diagnosis might be different. But presumably that's because the themes and the challenges, there's so much overlap with whether it's naps or like, even winding down for sleep.
Exactly, 100%. It's really, there's this idea of like protocols. Like a lot of people have said, do you do CBTH? Like, do you do this? Do you do, how many sessions is it? That stuff really is like really much more research based that people are doing in research studies. And I find that, you can't necessarily say, okay, in this session, we're going to discuss the issues with your family and how they're not supportive or they're supportive and like child stuff. Like, I think that it needs to be more flexible based on the person, but within those constructs of the kind of areas that we talk about that we know can be beneficial.
Right. So I know that you've spoken, and for our audience, and we will share this, your social media feeds, because it's so educational and jam-packed with great information. It's a resource, right? I mean, even just that.
Try.
Yeah, absolutely. And some of the other work that you've done on mainstream media. But what would you say to people with a sleep disorder when they hear you talk about, say, having blackout blinds or the wind down, and they say, well, that's not relevant for me because I have a sleep disorder? What would your response to that be?
That is something I try as often as I can. Like sometimes I'll cut you off on TV because there's like only so many things that we can get in. But I really do try to be responsible in as much media as I can to say these are things that help the person who has the occasional issue with sleep or who is looking to, quote unquote, as everyone likes to say now, optimize their sleep routine. But if these things aren't working after 2 weeks, that's not the treatment for you. So for someone with a sleep disorder, what I will often say is then I want you to think about, if these aren't working, think about going to a sleep specialist. Think about, I think it's hard to give specific advice for all sleep disorders because there's 60 plus out there. But I will always say sleep hygiene is just the tiny, tiny tip of the iceberg. There's so many other treatments out there that are really necessary, and I don't want people to feel like they're being left out when the media is really just making it sound. And I think a lot of people on Instagram, and that's why I started my Instagram, were like, blackout shades and a relaxing wind down will solve all sleep problems. And the reality is that's not the truth for most people.
But it might be just another hack. And, one of the challenges I think with a sleep disorder like IH and narcolepsy is that you need so many kind of elements to your day and night routine that, whether it's your diet or your wind down for bedtime or, of course, medication and your nap routine in the day. But I think my question is, those smaller pieces, even whether it's blackout blinds or no screens and things like that 2 hours before bedtime, they are still significant tools, correct?
Oh, 100%. Yeah. But I think people will say, well, I'm getting light in the morning. Why is that not helping with my sleepiness? Right? If you have IH, light is useful, but it's not usually, if light was the solution for most people, we wouldn't have all the treatments that we have.
Right. Okay, so I'm going to jump into another theme here. You talk a lot about the difference between being tired and sleepy. And I wondered if you could just expand on those two kind of words, really, and how that might be relevant for our community.
Oh, I love that question. So tired, this is something that really resonates with a lot of people who have insomnia. So a little bit different. But people who have insomnia, unless they have a co-occurring issue like apnea or depression, they will often say, I'm super sleepy. I just can't sleep though at night, or no matter how much I try to nap, I can't sleep. What they're really responding to most of the time is fatigue, so feeling tired. I always say it's like that feeling of just dragging around like a ton of rocks behind you or a bunch of bricks. Like you just can't do anything. And by the end of the day, you're just spent. But it doesn't mean that you're necessarily going to fall asleep. So a lot of people who have sleep problems at night, they're getting in bed at a time when they're not actually sleeping. Now, the difference is with people with IH, narcolepsy, who have hypersomnia issues, they are feeling excessive sleepiness. So it's the irrepressible need for sleep. So when we give a common questionnaire that we give to a lot of people would be like the Epworth sleepiness scale is how sleepy are, what's your chance of dozing in certain situations, like quiet sitting after lunch, as a passenger in a car. If you are routinely having a high chance of dozing across multiple situations, that's when we start thinking of hypersomnia. So that's a different issue, or excessive sleepiness issues. And then we start thinking, what is the cause for that? Is it medication? Is it IH? Is it narcolepsy? Is it apnea? There can be a bunch of different reasons. But sleepiness is that I'm sitting down, it's quiet, maybe not even quiet, and I just have this irrepressible need for sleep.
Mm-hmm. Yeah, that's a really helpful distinction. So just like thinking about the challenges we have in today's society are obviously quite different to even sort of 10 or 20 years ago. Have you got any advice or recommendations for technology in terms of what apps might be helpful? Let's start there, because I've also got a question about gamification. But go on.
Apps for what specifically?
Yeah, for just monitoring and managing sleep health.
You know, it's interesting. I am so old school because I started practicing before.
I
write everything down. Some of my younger patients are like, seriously, there's an app for that. So for me, I am an old school, like there are apps that you can get for sleep diaries. You can get a lot of that stuff. Mm-hmm. I am one of those people who's just like, write it down on a piece of paper and just email it to me or upload it to our portal. But I think there are tools out there. So like there's one of the things that we do in CBT, the cognitive part for some people is challenging some of the beliefs that you have about sleep, or being almost problem solving some of those things. So this person won't like me if I cancel on whatever because I'm too sleepy, or I like whatever it might be, and the beliefs that they might have. I think like the CBT Thought Diary is a wonderful app to help give you questions, prompts to help challenge the thoughts that you're having. And it's a very standard tool. I used the old school paper version for a long time. And it's really like, what would you tell a friend? What evidence do you have this is true? And if it's actually true, or if there's evidence behind it, then we figure out how to problem solve it and work on moving forward with that person if you need to cancel for whatever reason. So the CBT Thought Diary is a wonderful one. I'm a big fan of meditation. Mm-hmm. So we were talking about, like, you still want to do wind down routine. You want to have it dark at night, light in the morning. Like, those are all important things to do still, just to help kind of set your circadian rhythm. So I love there's a million meditation apps out there. I've worked with most of them. I don't get paid to recommend them. But like Calm, Headspace, Meditation Studio, and then there's Insight Timer, which is free. I think you don't need to have an app to do meditation, but it helps to give you something to focus on. And meditation is important to do during the day so that you can recognize when your brain's getting busy. It's not necessarily meant to hypnotize yourself to sleep. But if you want to use it that way, that's okay. Yeah. Those are the two big ones that I use. And then there's like ones for insomnia. There's a bunch out there, but I use the thought tracking one all the time with patients, and meditation ones.
Yeah. That's really helpful. I think there's so many resources that are free, as you say, and
so many.
It's just to sort of change, to challenge ourselves and maybe change some habits and implement some new tools. Like meditation is a bit of a shift, but it's a really significant one. I don't have a sleep disorder, but I'm pretty heavily dependent, I think, on meditations. I use Insight.
Meditation is like
amazing.
Yeah, but the thing that I always caution people with, though, is that the apps, the trackers, a lot of the apps have trackers along with them. I think we have to that's why I actually try to stay away from tying everything to technology, because I do find that sometimes it makes the hyper focus on things even worse. And if you have, let's say, narcolepsy, you have a diagnosis of narcolepsy. Do you need an app to tell you inaccurately a lot of the times how often you're up for in the middle of the night? We know those are issues. So I think sometimes if it's not helping you to change and make change in the way you're treating whatever issue it might be, then I think it's just extra data that can cause more anxiety in some people. And we know the sleep staging on some of the stuff can be a little off on some of the trackers too. So that can also make people who have sleep disorders like more worried about things when it's not that accurate to begin with. And,
it's such a good point, because with, say, meditation that addresses just mental health generally, what would you say about the role of kind of poor sleep unrestorative sleep in sleep disorders.
Yeah.
What impact does that have over time on mental health? Let's start there.
Huge. Yeah, I think it has a huge impact for a lot of people. So unrestorative sleep, for some people, really can make it harder to, let's just say during the daytime, manage stress, do the things that you need to do, even if it's like a day or two. And the more that those things build up, your trouble with tolerating stress or irritability or not getting things done as efficiently as you like, that can then set you up more for any sort of a mood issue. It doesn't have to necessarily be a mood disorder, right? Like an actual clinical depression, but we do know that sleep loss and poor quality sleep in many people can set someone up or be a precursor to a depressive or anxious episode in some people, or even like manic disorder, bipolar disorder. We'll see that sometimes. That it's really important to try and target it as much as possible. And the thing that I also do stress for a lot of people who have sleep disorders is that in the traditional psychology, psychiatry model, remember, a lot of people who are in the mental health field just don't have good training in sleep to begin with, and especially not much training, if any at all, in any of the hypersomnia issues. So IH narcolepsy, there's very little training in it. So people automatically think, let's work on the depression, let's work on the anxiety, let's fix those issues, and hopefully that's going to help the sleep issue. And the reality is it's actually the reverse.
The other way around.
I stress to people, try to work on the sleep, at least get some handle on it, and try to find something that works in your life. Maybe be in therapy at the same time. But getting the sleep under control is really, or at least trying to work on it, is the key for many people.
And the same thing applies, I imagine, to cardiovascular disease.
Yes.
And I know you've spoken a lot about this, and also in your book, which is on Amazon, I think. We'll do a tag to that, specifically focusing on sleep issues in women. Can you just talk us through some of the cardiovascular impacts as well?
Yes. So the more that you have trouble with sleep, right, what that can do is actually raise your blood pressure. It can, which then can put you at a higher risk for stroke, heart attack. Any cardiovascular issues like down the road can really be a big issue. And then the other thing that we see a lot in poor sleep can be things like, and we see this even, in a lot of we see it in a lot of patients with narcolepsy and IH. We'll see comorbid or co-occurring in sleep apnea. And so you're having sleep apnea that's happening on top of unrestorative sleep or poor broken sleep at night. And that can really increase your risk of heart attack and stroke.
Yeah. Everything's so interconnected. It's so important to address sleep from all manner of directions. So thank you for shedding light on that. This might sound a bit random, but about 6 months ago, I came across a horrible word I didn't like. It's called bed rotting. And and it was really triggering, obviously, because my daughter has narcolepsy and she naps. And there are some days where I think she wishes she could spend all day in bed. And, obviously... that's not going to really work. So what are your thoughts about bed rotting? So it seems to be kind of like culturally acceptable somehow.
Yeah.
And I just wonder if it would be detrimental to people in our community.
First of all, I can't stand the name. I think the things that tend to catch on the most and become the most viral are the things that have the worst names.
Probably.
And that give people this feeling of permission to be able to do things that they feel like they shouldn't be allowed to do. So... taking out of the name, the idea is just that you're staying in bed and you're just kind of rotting away in bed. It's terrible.
It's awful.
I think there's something to be said for the occasional, as people will call it, mental health day, right? If you're tired, if you're like, I've had those days where I'm just like, my kids are away and I just need a day to just like chill. And I will do that. And I will spend a few hours. I don't rarely spend a day in bed. And I think that's fine. But the thing that we need to think about is a few things. So with people who have any sort of IH or narcolepsy, right, we do want to think, yes, napping, I think, is totally appropriate, rest, all that. But we also do need to think about movement, light exposure, exercise, all those things that can be more alerting for many people and to help with sleep at night. So we need to, it's not necessarily ideal. I think if you do it once or twice, fine. But the problem is when it becomes like I'm bed rotting for a few days in a row, that can worsen any sleep disorders in many people or feelings of sleepiness. And I think what can also happen for some people is it can be kind of covering up depression or an anxiety about wanting to go and do things that if we just call it bed rotting and it's good for my health, it's really, for some people, actually worsening mental health.
Yeah, it's a really interesting kind of newish thing, I think, that had piqued my interest. And I was like, oh, I'm not sure I like that. But yeah, interesting. And with that, if you're staying in bed for extended periods of time, you're not getting that light exposure. So let's just touch on light exposure and circadian rhythms, and maybe you could comment if you have any thoughts about how daylight savings might impact people with sleep disorders.
Yeah, I mean, daylight saving is bane of my existence. I know that it's coming a lot of times because my patients are often thinking about it weeks in advance, and they'll mention it to me. So it's really not great for our circadian rhythm. So our circadian, about a day, that's what it means. Our body has this natural clock that's about a day long. And it's actually a little longer than a day, believe it or not. They used to do studies, I believe they did some at Montefiore many, many years ago, where they did a lot of circadian research initially. And they would put people in a lab in a room with no windows, no knowledge of what time it was. And you would see that their natural body clock, they would just start staying up gradually later and later and sleeping later, because that's what our natural clock is. So that's why we stress the continual keeping of your consistent bedtime and wake time for many people, because it's the wake time that helps keep that from progressing and keeps our body clock in check. Now, what are things that help to keep it even more in check? So light exposure is really important. So light in the morning and throughout the day is really helpful. That helps to set our body clock by stopping any melatonin production. Light can be very energizing for some people, not everyone, but for some people it can be useful. And then at night, we have to think about the clues and the cues for our body that would really signal that sleep is coming. So what would that be? It's the opposite, right? It's darkness. It's dimming the lights. It's doing things that are a wind down, that are quiet, calm, relaxing. Those two anchors on both sides are really what help keep our circadian rhythm in check.
Yeah, it's really helpful. And with that, then screens, because that's another, it's just so different, isn't it, to years ago. We would never have had this conversation, and now it's really pervasive, and we're all having to check ourselves. So what would you recommend, when to shut down screens prior to sleep?
It's so funny. I used to, when I first started practicing, the question we always had in the questionnaire at Montefiore, and that I still find myself asking, is, do you have a TV in your room? Do you watch TV? And it's so rare that people are watching TV. They're just on their phone now. Phone. It's amazing how much it's changed. It's interesting that the blue light is not ideal, but it's actually more and more is coming out showing that it's not the devil that most people make it out to be. So it's really about light exposure in general. It's not about I have to put on all the red blocking, the blue blocking glasses that make my whole room red. It's really just about brighter light exposure. That's what your brain is thinking is the sun. So it's not great, but I do have some people right now that I work with that are I just need to listen to The Office to help me just quiet my brain down. And if that's working for them, I'm not going to make a huge issue out of it initially. Right. But I think the bigger issue for me with the screens, honestly, is that we get sucked into it a lot of the time, and that we're doom scrolling, and that can then activate our brain and make us just there's these things, a lot of them are meant to be addictive. So it's hard to put it down, and then you wake up in the middle of the night and you might look at it again. It's very addictive. So I think trying to get rid of it and just uncouple the screen for bed so you're not so addicted to needing it to fall asleep is useful for a lot of people. So I would initially recommend 30 minutes to 60 minutes, and that's a lot for many people. So if you're used to falling asleep with the phone in your hand, maybe 5 minutes before bed, put the phone to the side. Keep the phone. The ideal is to get an alarm
out of the
clock.
room.
And get a real alarm clock and keep the phone out of the room. Or at least, if that's too big of a step, then put it across from your bed.
Because even alarm clocks on our, it's almost like going backwards, isn't it? It sort of suggests, well, let's get a traditional alarm clock from somewhere, and because we've even got alarms on our phones.
I still have the same alarm clock from high school.
Oh,
we were talking mid-90s. I still have. It's dying. It needs to, but I love it. It works.
Yeah, it works. It's so cool. Thank you. That's all really helpful. And we could do more and more. But I do want to let everyone know that you will be speaking at Beyond Sleepy Hour annual conference in June. It's in Houston.
I'm excited.
Yeah, to actually meet you in person would be wonderful.
That'd be great.
We'll have many people from our community there. So if you're listening to this and you can join us in Houston, you get to meet Dr. Shelby Harris in person and hear more about what she's got to say in terms of her expertise on sleep and CBT. But for now, thank you so much. It's always a pleasure.
Claire, thank you for everything you're doing in this space. It's really a game changer. Thank you.
Thank you.